Good morning, everyone.
Morning.
There's Perry. Hi, Perry.
Good morning, everybody. Hey, Katie. Hey,
How are
Rich.
you?
Good. Good to see you all. It's been a while.
Yeah, it does seem like it.
So, is this our end of year celebration?
This is our end of year celebration. We're celebrating with a fantastic presentation by Dr. Gordon.
Great, great, great. I think I just put somebody in touch with him. I think I just recommended somebody they sign on to this who's very interested in the whole, substance abuse issue. I can't remember who it was, but maybe we'll have a new name or face on our call.
Good.
Hey, Matt, Misty, Mike, gosh.
Good morning.
Like old
Yeah, it
friends.
does seem like it's been a while. I'm not sure
Okay.
why. Maybe because we met last month, right?
We did. Maybe it's because some of us have been traveling, right?
Yeah, maybe. And there's Mike. Hi, Mike.
Hello, morning.
And some of you know this, but Sarah Ponce, she is out of the office on vacation, and so she won't be joining our meeting today. But Sarah Lalos, of course, is here. She'll be running things on presenting. Then Danielle Conlon will be taking minutes of the meeting. She's our outreach specialist.
Yeah, thank you for stepping in, Danielle. And
Yeah.
Sarah Layla, stepping in and out and in again, I think. We really appreciate that. And there's Adam. Hey, Adam, we're so excited. Thank you so much.
Welcome, Adam.
Nice
And
to be here.
you're
Thanks
the
for
good.
inviting me. Again,
Yeah.
you know you did a good job the first time if you get invited back.
Exactly. Return customer. Well, you're the good stuff for the meeting, and we'll get to the good stuff quickly. And let's see, what time is it now? I'm wondering if we should get started.
Yeah, looks like it's 9:02. We've got everybody but Dr. Zender.
Well, I think we should go ahead and get started. What do you all think?
Yeah. Sounds good.
Okay, so you'll have to bear with me. Last time you'll have to do this while I read the script. It just has never come naturally to me. It still hasn't, but here we go. This meeting is being held virtually and is hosted by the Utah Department of Health and Human Services Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared for this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. So a reminder of our purpose: to review the available research literature and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. A public comment period will occur at the conclusion of this scheduled agenda. Comments will be limited to 2 minutes per person, and we will take comments one right after the other. As a courtesy to everyone participating in this meeting at this time, I request that you place yourself on mute unless you are speaking to the group. Board motions and votes will be recorded in the minutes. We will now turn our attention to the agenda. Okay, so welcome everyone. I'm not sure if others trickled in since we got started, but it's really good to see everyone. And let's start with approving the minutes from last month's meeting.
So moved.
I'll second that.
Okay, let's vote. All in favor of approving the minutes, say aye or raise your hand where the camera can see it.
Aye.
All opposed? Any abstentions? Okay, minutes are approved. And there's Brian. Hi, Brian. Great to see you.
Aye. Good morning.
Okay, so this, we squeezed this in, the statement on insomnia, and we're going to really limit our time here. So if you all decide we need more time, we'll just move it to next month. But you were all sent a copy of this, although it was in the form, originally it was sent as part of Lauren's kind of deep dive into the literature on insomnia and cannabis. She then revised it without changing much comment and asking for feedback into what was titled guidelines for cannabis or cannabinoids for the treatment of insomnia, discussion guidelines. So I don't know if you all recall this, but it circulated March and April. And this is a distilled version. The original version that she sent was kind of some summary bullet points, and then a much more detailed explanation of each study. So we, and from our last discussion, as you recall, we were able to generate a very brief letter to Senator Vickers, simply stating that there is insufficient evidence to recommend insomnia as a qualifying medical condition, or to recommend, I can't remember the exact wording, to recommend cannabis as a treatment for insomnia. So like we have done with a few other topics that have been floated our way, and interesting that Dr. Gordon is here. This includes cannabis for the treatment of opioid use disorder, cannabis for anxiety, and now cannabis for insomnia. So none of those three are qualifying medical conditions as written into the law. But we did look at them because there has been interest in trying to get those to be approved as a QMC. And so what we did with those other two is we put basically a statement on our website stating that there was insufficient evidence to recommend that those conditions be considered qualifying medical condition. So I would like us to do the same for insomnia. We did all the work, starting with Lauren's deep dive, our review, whatever back and forth there was, our discussion last week. I would like us to take a vote, if people are in agreement, on whether we can approve this as our statement for insomnia as a potential qualifying medical condition.
I thought this
So-
was a really good explanation and summary of of the material. And so I would like to make a motion that we approve the statement as recommended by the board.
I'll second the motion, and then comes discussion, right? I thought this was also a very good summary.
Okay, so are you saying, Matt, you want a discussion?
Well, that comes after a second. So when you have a motion, then you have a second, then it's open for discussion.
Okay, thank you. Well, we have a second. Let's have a discussion.
You know, my only comment is I think this is really well distilled. I think it was effusive in my praise of Lauren Heath, Dr. Heath's review last time around. And I revisit that. Lauren thinks this is, really good work, and it was able to be manifest much more quickly than in the past because of your skills and your efforts, and take it out of the hands of board members per se to have to do this, but then just take your work and then to think it through. So I can't think of anything to add or detract from it. I think it's well distilled, well edited. I think it's going to disappoint a lot of people because my sense over especially the last couple of years, since I've been talking about these matters with a lot of different sorts of folks, is that other than chronic pain, insomnia, sleeplessness, difficulty in getting to sleep, and staying asleep, as people sort of in lay language describe it, is one of the main reasons people seek out cannabis in one form or another, oftentimes from other sources rather than from the medical cannabis program. There's all sorts of gummies and things out there that, even though they're not supposed to, purport to be useful for all sorts of things, including sleep disorder and insomnia, etc. So I think a lot of people are going to be very disappointed by this. It's probably going to not be accepted with praise, with acrimony, but nevertheless, I think this is an intellectually honest, effort, and it does exactly what our directive is. I want to sort of remind this. Katie usually introduced this, and so I didn't really say anything at the beginning, but I also want to underscore it, having served in that position for quite some time, that this is our directive: is to look at objective indicia, i.e., review the evidence, review research, review, as well as this time, we went further and discussed our own personal experiences as clinicians in helping to manage folks with this condition, and sort of qualified the discussion as such. And I think we've come to a conclusion that's honest, has integrity, and will stand. Over the course of time, it may change, just like every other condition we've reviewed. New data may alter things, and future groups may come to different decisions. But this one, I think, has been arrived at with great integrity. So thank you, Lauren.
Yeah, and thank you, Perry. I agree. I think I want to be mindful of the time. Are there further comments, or do you think we should move to take the vote?
Well, I just want to add to what Perry said. I agree with this, and I think because even though people are going to be disappointed, in no less than 3 places, this document makes the point that sleep was a secondary benefit.
Yes.
And we made the point that this is, I've used the term primary insomnia, even though that's antiquated, but we made the point that even though it's a secondary benefit to sleep, secondary to pain or any other condition. So as long as that point's made, I think it's, like I say, it's intellectually honest and it's justifiable. And if people are disappointed, we can't control that, but this says what it needs to say.
And to validate Perry and Matt's comments, it's just another example where more research is needed. We're limited by the insufficient evidence at this point.
Yeah, yeah. I agree, Misty. I think we've done this often enough now. We're fairly familiar with what the kind of general themes are in terms of what the deficits are for all of these potential conditions. And I agree also with the comment that things will change over time. But we are tasked with reflecting back what's in the science, you know, what's in the literature, not getting ahead of that. So, any other comment? All right, let's vote. All in favor of approving this document, say aye, raise your hand.
Aye.
Aye.
All opposed, say so, raise your hand. Any abstentions? Okay, so document is approved. Thank you for that. And I heard Jennifer in there. So hello, Jennifer.
Aye.
Good to have you. So let's get to the good stuff. As I said, we have Dr. Gordon here. We have had the pleasure and honor of listening to a presentation from him it was 2021 actually, on opioid use disorder and cannabis as a potential treatment. And we are lucky to have him back today. Very much appreciate that you took the time to do this, Dr. Gordon. And I will not be able to do justice to properly introducing you, but you will see on the presentation that you'll get a reminder of what Dr. Gordon does and some of the roles he plays, and why his input is so valuable for this effort. So take it away, Dr. Gordon.
Thank you so much. Can you all still hear me?
Yes.
Yes, we can.
All right, I think let's do one more thing here. It's really a pleasure to be with you all again. I think it's, yeah, so really nice to be back with you all again. And I have a very specific task today. I was asked to talk a little bit about the association of cannabis use and cannabis use disorder. As you all know, I'm Adam Gordon. I'm a professor here at the University of Utah. I work with the VA Salt Lake City as well. I have a couple of just introduction slides because I got some comments last time about you know, who are you? what are you doing? So I wanted to give at least three or four slides here about who I am. I'm not going to have you read this. I know this is for public comment, so if people want to read a little bit about who I am, what kind of research I'm involved with, etc., it's on this slide. I want to make sure it's very clear. I have no disclosures, no fiduciary conflict of interest. I do serve on 3 board of directors in the last year. They're a non-for-profit. I'm not remunerated for them. And because I do work with the federal government and the University of Utah, I just want to make sure that it's very clear that I'm not speaking on behalf of any organization, government, institution, or agency. I do want to recognize that many of you asked last time about where I work. So I'm at the University of Utah. We have a program for addiction research, clinical care knowledge, and advocacy, or affectionately called PARCA. We do a lot of work with regards to research, clinical care, education, and community advocacy work. And on the next slide, just a little bit of all the trainings we've done in the community. We do some things like buprenorphine waiver trainings and now buprenorphine 101 series. We have monthly webinar series that we broadcast all across the country called PARCA Parleys, as well as On the Rocks, which is a little bit more research focused. And we do quite a bit of research, including, and I want to make sure it's very clear, some of our faculty here are involved in some of the medical cannabis evaluation that you all are involved, the cannabis board here is involved with as well. We have a lot of faculty and a lot of mentees all across the country. You know, certainly we have resources to expand. If you guys want us to say, for example, hey, we want to look and do a systematic review on the associations of cannabis use with cannabis use disorders, we're able to do that relatively easy because of our staffing as well as our expertise. Okay, So with that background aside, this is the central question that we want to deal with today. And by the way, I'm able to look at the chat, so feel free to go and put things in the chat, or we can just have the 10-minute discussion at the end. I'm going to end on time at the top of the hour. I think I have until the top of the hour, and this should be a fun little exercise. It is a not a very controversial subject, actually. And the controversial subject is how important is the relationship, as well as how important, what is the magnitude of the problem? You know, if everybody in the country was smoking cannabis or using cannabinoid products, how many of them would be eventually addicted to it or have a cannabis use disorder? And we're going to talk a little bit about what that means, as well as the harms associated with that use disorder. I'll just stop here, though, and rather than me just talk forever. What do you think, if you were a daily user of cannabinoid products, what do people on the board think, or anybody in the audience think, is the percentage of people that will eventually have a potential cannabis use disorder? So what is, if you use on a regular basis, on a daily basis, what is the percentage of people that would have a cannabis use disorder? Anybody hazard a guess? Why don't we make it a verbal comment here? Make it easy, make it easier for me to see, to hear.
9%.
9%. Anybody else?
20.
What's that?
20.
20. Okay. You're
Well,
all.
I think Samsha and NIDA report somewhere averaging around the meeting around 12%, which amazingly seemed very similar to opioid use disorder and alcohol use disorder. That there seems to be, the variants may differ, but I seem to remember, Adam, that struck me as being amazingly, remarkably similar.
Yeah. So
And-
go ahead.
And I would just add that my understanding is the rate of cannabis use disorder differs depending on the age. So the younger the brain, the higher the rate.
And I said something very specific when I asked that question, by the way, which is going to which tripped you all up. And what I said, if you're using it on a daily or regular basis, it's a much different percentage than you guys are thinking of. In general, the 10%, we'll talk about a little bit later. I'm going right to the conclusion here. The 10% that people have actually mentioned is those people who have any use over time. So it's any use, whether it be in youth or in older adults. That's the general thought, that those people will have a 10% chance of becoming a cannabis use disorder patient. However, if you use on a regular basis, on a daily basis, the percentage is much higher. And actually, I learned a little bit more when I was looking at this in terms of the epidemiological literature. It's about 30%. So if you're using, you will have indications of a cannabis use disorder enough to meet the criteria 30% of the time if you're using on a regular basis, which certainly has a lot of implications. For
Adam,
medical
I'm
safety.
sorry. Can everyone mute their microphone, please? There's some background noise. Go ahead, Adam. Sorry.
Yeah, so it has a lot of implications if you're taking it on a daily basis for a medicinal purpose, that you're more likely to be more regular use. So we'll talk a little bit about the epi. We'll get into the science a little bit. I have a couple of slides just to give you all know a lot of this stuff, but I want to make sure that the public who may be listening in get some of the information about use, as well as the harms associated with cannabis, before we dive into the central question we're going to talk about today. As many of you know, cannabis is ubiquitous in our society. We really concentrate on the right side of the screen, where people are using, at least 20 million people in the United States are using it on a monthly basis, about 35 million a yearly basis, 35 million at least on a monthly basis. And about 78 million other Americans have actually tried it at once. So some of the percentages that we're talking about, the 10%, which we mentioned earlier, incorporates those people who have ever used, who have tried it as an adolescent or tried it as a young adult. But those people that we're really worried about, especially for cannabis use disorder, is those people who use it on a monthly basis. Those 35 million, actually it's about 40 to 50 million on estimates now, who regularly use cannabis, either for recreational purposes or medicinal purposes. And it's a large population. So a lot of population has been exposed to cannabis. And that's really important when we talk about the causal opportunity for an addiction or use disorder. So just to give you a smattering of how this compares with other substance abuse that I deal with all the time, on the left side of the screen, you see the drug usership among Americans aged 12 or older. The blue line represents use at any point in their lifetime. So about 50% of United States Americans have tried it at least once in their lifetime. Green line indicates use in the last year, and the gray line indicates those people who used it in the last month. And you can see that marijuana by far exceeds all the other prevalence or use of both cocaine, LSD, ecstasy, methamphetamine, and even heroin. On the right side of the screen is another way of graphically showing this. You can see that marijuana use is really the number one illegal drug in the United States. And it's estimated recently that about 43 million people reported using it in the last year. And again, the most commonly abused or illicit drug in the United States. It's interesting to note, I have one comment on one thing that I just want to as a little aside. One of the things that are, as addictionologist, as addiction medicine provider, that I really worry about is the use of one substance that will potentially cause polysubstance use of other substances. And this is a really nice graph. It came from Wilson Compton at NIDA, where they looked at the prevalence of co-use of other substances of a primary drug. So for example, on the left side of the screen, you can see alcohol and the use of alcohol, and then the mean number of other substances ever used. And you can see that if you drink alcohol, you're likely to have 1.8 substances that you will use in addition to the alcohol. The concern about marijuana, if you look at comparing to everything else, is that it's high prevalence and lifetime prevalence, the 48%, which we heard the other slide. But we often have co-occurring polysubstance use with this use. So bigger than many other things that we think of, especially alcohol and cigarettes, but 2.9 other substances are used. And that includes other hard drugs, cocaine, PCP, for example, often co-occurring with marijuana. But I just want to emphasize that it's often a problem if you have a use disorder. You're often dealing with many types of addiction, and therefore you have to get into really intensive care for these patients. Intensive care in terms of intensive outpatient program or an inpatient program. You're often dealing with comorbid polysubstance abuse. As many of you know, and I'm not going to reiterate this, I'm going to say it a couple of times, but the major concern from NIDA, as well as researchers in this field, is that we're seeing a dramatic increase in young adults and adolescents using marijuana. As you know, the adolescent brain is still evolving, and there is major concerns that exposure, when you are an adolescent or young adult, you have a much more prone chance of having a use disorder over time. And this slide just recognizes that we're seeing a dramatic increase in the number of adolescent and young adult patients who are actually using marijuana. And that is a major concern down the road when we're dealing with a cannabis use disorder and we're actually having to treat it. Certainly the marketing has been targeted toward youth, and that's something that we see all the time. You all know this stuff. I'm not going to go into it, but it's certainly a targeted youth exposure problem. Real quickly, pharmacology, you all know this as well. Two major products in the cannabis, the THC and CBD. You all know that THC is euphoria-based, and the CBD is really the medicinal side of the cannabis. It is an addicting substance. Many people don't recognize that. And it's something that's really important that the THC products are getting much more popular, higher THC concentrations, and you all know this. But the thing that people don't recognize, and you may do, but the public doesn't recognize sometimes, is that you can get dependent on cannabis. And this dependence can cause a lot of problems. We actually have hospitalized people coming off of cannabis. We've treated people as an outpatient who are having problems after they stopped their exposure to cannabinoid products. And sometimes it's a very difficult disease to treat as you're dealing with that withdrawal syndrome. We'll talk a little bit about what that withdrawal syndrome is going to look like in the next couple of slides. This slide just basically emphasizes that the trend is for more potent THC products. A lot of studies have come out recently just seeing how the dispensaries or the illicit products on the market are really emphasizing a hallucinogenic THC product, not the CBD, which is the more medicinal product that we recognize. And you all recognize this as well. And it's something that big issue in terms of even dispensaries of how what are the products being sold at these dispensaries, and are we emphasizing the THC products such that you're having more prone to addiction because of that THC concentration. People can get intoxicated to marijuana. You all know this as well. A lot of different signs and symptoms can occur. The biggest concern that we often see is the psychosis, the anxiety and psychosis that actually occurs with cannabinoid intoxication. This can actually hospitalize people. We've actually seen some accounts of this in the United States, certainly around the world, where we have people with acute psychosis and psychotic breaks, and often have a lot of problems with handling, driving or handling, in hazardous situations, which can cause them problems and have you a use disorder, which we'll talk about in a couple of minutes. The withdrawal effects of cannabis is a lot of insomnia, anorexia, irritability, depression, and in a very acute tremor. Actually, about several years ago here in Salt Lake City, I was dealing with someone who was coming off of CBD products. And what happened was that they had this like a seizure almost, a tremor. They couldn't really handle anything. And we had to put them on some benzodiazepines actually to help reduce that tremor and make him a little bit easier to go. The withdrawal can actually last for some time, up to 10 hours to start. And usually that person actually had a 10-day course of these tremors that when he was coming off the CBD products. We have hospitalized people. We anecdotally have seen that in the literature, some case reports of acute intoxication, but more importantly, the concern about the withdrawal just to manage the sequelae of coming off of that product. Medical consequences, there's a lot of medical consequences of illicit as well as regular cannabis use. I'm not going to go through this whole slide, but it basically does impact quite a bit. The literature is not too cause and effect on this. It's a lot of correlation with different medical diseases. But correlation just means there may be an association, but it's not a causal link. But there are certainly diseases across different health systems in your body that may be impacted based on marijuana. Last little introduction slide is a little bit about consequences of legalization. You all know that there have been problems associated with legalization across the country. We've anecdotally seen a rise in emergency room visits in states that now and mentions of marijuana use in those emergency room visits. We've had increased suicides in some states. And just next door in Colorado, we've been watching this for many, many years now. When Colorado basically made cannabis products recreational and legal, there's been a lot of push to say, well, wait, all this revenue we're actually putting back into the healthcare system to take care of the consequences associated with that legalization, particularly DUI. That's been the Colorado experience. We've had a lot of driving under the influence of marijuana products. And if I remember right, a couple of years ago, I heard a report that actually the marijuana DUIs actually exceed those of alcohol in Colorado, but don't quote me on that one. I want to mention to you a little bit about the major health effects that Nora Boko, who is the director of NIDA, basically testified to Congress for. And these are the six, actually. There's one that's missing. The first one is prenatal and adolescent development, where actually there's a large study going on, a cohort study called the Monitoring the Future study, where people are actually watching the content, what's happening with exposure in youth. And then there's several cohorts, the ABCD study, for example, which are looking at long-term consequences of marijuana use, both in the childhood age, adolescent, and young adult. Mental illness is a huge issue associated with harmful health effects. Lung injuries has been controversial, but there certainly is association with some inflammation in the lung, many other medical complications and impaired driving. But the one thing, the second bullet that I didn't put on the slide yet is this. the National Institute of Drug Abuse is extremely concerned that we have a cohort of patients who are going to have been exposed to cannabis, either in a medical realm or in a recreational realm or illicit realm. And this could cause a lot of problems down the road. We may be dealing with a cannabis use disorder crisis in the near future because of all our new exposures that we're having both in youth and adults. So just to talk a little bit about what a use disorder is or an addiction, this is kind of my way of thinking about things. Every addictionologist does it a little bit differently. Thinking about no to some consumption on the left side of the screen, we want to prevent people from using illicit substances. Many times people will start using something like alcohol, or maybe you're taking a prescribed opioid, and they may have misuse or at-risk consumption, kind of risky behavior. And oftentimes you use behavioral means to take care of those patients. But those patients may evolve into what we call a use disorder, and a use disorder is an addiction. The addiction is a specific criteria, which we'll talk about in the next slide, which is the disease. And it's defined by criteria that we all know and love through the DSM-5. And this means that you have an addiction, that you have a harm associated with your use. It's really important just dabbling with it. Just now, with marijuana, it's a Schedule I medication. So we're not medication, but a Schedule I drug. So anytime you're using that, technically, if you're not legal in your state, you are using an illicit substance, right? But you had to procure it, you had to go find it, you had to use it. And that could cause trip you over to have the addiction criteria. This slide actually talks about the addiction criteria. I'm not going to go through all of them, but if you scan them, you can see that all has to do with harm associated with that use. There's a lot of thinking about procuring a substance, any substance, then using it, and you're using it potentially in hazardous situations and causing harm, not only to yourself, but to other people. So a good example for what we see in marijuana use is that, so someone would start to use, and then maybe, your wife or your significant other would say, oh, you're smoking too much, you're not paying attention to your bills or our family, you're missing ball games of our kids. Though that would be a criteria in and of itself, one criteria to fill a cannabis use disorder or marijuana use disorder. If you have dependence on this, if you're especially in your state that's illegal, and you're not prescribed it by anybody, that would be another one immediately. If you had withdrawal symptoms, you would have another criteria. So just those two criteria alone, you would make the definition of a use disorder. Now, in our world, there's been a big push to think about pre-addiction versus addiction. And usually we're really thinking it's a serious condition or a major problem when you get up to 4 of these criteria. And there will be, this criteria, by the way, is the same for opioids. It's the same thing for chocolate addiction, whatever addiction that you have that's involved with the substance. So with that, so now we're going to talk about the epidemiology. We're going to talk a little bit about how many times do we have people from a cannabis use that will go over to have the criteria for a use disorder. So I'm going to do the classic thing and tell you a little bit first, kind of a preview. We'll talk about each one of these things, and then what we'll do is we'll have a summary slide where we emphasize what we know in the literature, in the science. So the preview is that it's the most frequently abused drug. We just mentioned that. Use often leads to cannabis use disorder, and we're going to show you some of the studies for that. It is one of the most prevalent disease addictions in the United States. I'll show you a slide on that. We know that it's increasing use among adolescents, that we know that adolescents and young adults tend to have a more prone for cannabis use disorder. We'll show that. We know that there's been increased use in cannabis use disorder in states with medical marijuana laws. And interestingly, I'm going to emphasize a study that just came out last year out of Boston, I don't know this university, where they actually made a link that if you got a medical cannabis card, and you got it earlier versus later, you're more likely to have a cannabis use disorder. So cannabis use disorder is actually the incidence that's occurring when people are receiving their medical cannabis card. Okay. With that, let's dive in. 10 minutes, and then we'll have discussion. So as I mentioned earlier, we have a lot of use of marijuana, but we have a lot of use disorder. So this is a slide that basically said, not talking about use, but use disorders in the United States. So we know that about 14 million, 15 million people have alcohol use disorder, but right behind it, after illicit drugs is marijuana. About 4.4 million people have a cannabis use disorder in the United States. A huge problem, it's the disease. So this is not just use, this is the disease. Remember, the use was about 50%. Remember, 48% have had any use in their lifetime. And so you're a significant portion, even just by 7.4 versus 50%, you're seeing that there's a pretty high correlation with a use that could potentially cause addiction. Interestingly, we often talk about prevalence of a disease. So this first part of this slide talks about that marijuana use disorder in the past year, diagnosed in the past year, is about 1.7. But interestingly, if you start to count how many people have disability or a history that continues to have a problem, you actually go up to about 2.2% of the population in the United States. So recognizing now that we have about 500,000 more people based on, 1.2 million more people have continuing disability associated with the first episode that they received a diagnosis of cannabis use disorder, which is a huge issue. And it really imparts the problem that you're having long-term effects of this use disorder over time. So the data suggests, and I'm not going to go through all the epidemiological tables here, but the data suggests that nearly 10% of people who have used at any point will become dependent on it. Dependent means that they have an addiction, but more importantly, they could potentially have problems associated with withdrawal, requiring hospitalizations or treatment. We know that if you have used before the age of 18, so we're talking about the adolescents, you're 4 to 7 times more likely to develop cannabis use disorder in adults. So if you get it, if you have an exposure young, you're more likely to have it later. My understanding of the medical cannabis program here in Utah, many patients are below the age of 25 or 30 that are receiving medical cannabis. And that certainly is a concern because their brains are still what we call plastic. They're still evolving. And so they may have potential problems down the road. The risk of dependence or the use disorder increases for certain types of people. First, 17% more risk if you start using in their teens. And then it's 25 to 50% who use it daily. So if you're a constant user of cannabinoid products, you're more likely, especially with that THC content, you're much more likely to have a use disorder or an addiction down the road. So just in summary, it increases with frequent use and also exposure to high concentrations of THC, where you have the issue where a lot of products are being sold or marketed for that THC content. A lot of literature. I'm going to go back to the 30% slide that I talked about a little bit earlier. We know that if you regularly use cannabis, this is from several sources in literature, about 30% of that population who regularly will show mild to moderate disease of cannabis use disorder. There is a harm associated with that use. They may crave that substance. They may try to cut back. They may have other patients or persons saying that you're using too much, or what are you doing smoking that weed again? Again, harm associated with use, that's what is the definition of a cannabis use disorder. And we're seeing a lot of indications of that occurring in people who regularly use cannabis. About 23%, not 30%, but 23% of these people actually will develop severe cannabis use disorder. This often has a tolerance to THC, therefore they're urged to or wanting to take more and more of the higher concentration products. And they also have the withdrawal symptoms, which can be very vexing to treat as medical professionals. So the 10% is nice for any exposure, but we're really worried, especially for medical cannabis, about these percentages, because these people are regularly using this substance and at higher THC products, and maybe doing it for medicinal purposes, but down the road, they may be having problems associated with it, and they have a use disorder of cannabis. Again, I want to concentrate on the youth here. This is something that's a big push. I just came back from a NIDA conference last week. The director basically puts a slide very similar to this, to saying, hey, if you're a parent and you're using cannabis, you may have an exposure. The kids are more likely to use it. It's easier to find cannabis in rural areas than it is for alcohol. It's easier to find, to procure, because you have alcohol laws for age 18. There's not really any prohibition for someone to go out to get cannabis other than, you know, CBD oils, all that stuff. You have a lot of problems associated with exposure and youth. This emphasizes that on the right side of that graph, the percentage of cannabis use disorder among those with lifetime cannabis use. So if you're going to have a lot more adolescents and young adults that are going to be more prone to have that use disorder down the road. And basically that box on the right is very similar to this, that shows that those who initiated cannabis at a younger age are much more likely to have a cannabis use disorder. And looking at the history of that, the percentages are going up over time, which is the concern of NIDA and researchers. So this is the study that I mentioned. This is actually applicable to us today with the medical cannabis program here in Utah. This is a nice study that came out last year in JAMA Network Open. It specifically looked at medical cannabis and cannabis use disorder after getting a medical card for cannabis. It was an interesting study. I'm not going to go into too much details other than talking a little bit about the results. Basically, it was a randomized trial that involved 198 participants. They basically randomized people to have an immediate access to a medical cannabis card, and then at a later time, the other sample had a medical cannabis card. So they were able to see what would happen if you immediately got a medical cannabis card versus when you delayed it. And the idea was to look at some causal inferences about whether when you receive that card immediately, do you have more exposure or more problems with cannabis use disorder symptoms and other outcomes. The findings of the study, just in brief, suggest the need for further investigation, as we always do. But the concern that came out of the study was specifically about the incidence of cannabis use disorder symptoms, or the criteria that was a checklist. And the early people actually had more problems with cannabis use disorder and potentially then would be diagnosed with it. The slide here shows that. So I'll just read the conclusion rather than go through all the statistics here. But this randomized trial found that immediate acquisition of a medical cannabis card or medical marijuana card led to a higher incidence and severity of cannabis use disorder. It resulted in no significant improvement in pain, anxiety, depressive symptoms, and improved self-rating of insomnia. Apropos to some of our conversations earlier, this was an indication for the medical cannabis in Massachusetts. And further investigation was warranted. On the bottom of the screen, you can see figure 2. On the left side of the screen, you have the blue line is the immediate card acquisition, and then the delayed card acquisition group on the bottom. And you can see that once you started to receive that medical cannabis through the medical cannabis program, after receiving that card, you had a dramatic increase in the frequency of cannabis use. That's good. That's what their card is for. However, on the right side of that screen is the concern. So there were 3 indications that they used the medical cannabis card for, which was pain, insomnia, and depression. You can see that incidence of the cannabis use disorder by randomization group. So the left side of that table or graph, you see the immediate card group, and the right side is the delayed group. Again, the delayed group did not receive their card yet. Do they have incidence of cannabis use disorder? And on the left side of the screen, both for pain, insomnia, and depression, all those were increased compared to the delayed acquisition group. Okay. This is an open access article. Feel free to look at it. I was going to send it around today. I'm happy to share with the board. That was really interesting. It's the first one that I've seen in a long time that specifically looked at a potential causal relationship between medical cannabis acquisition and cannabis use disorder symptoms. It's a really important article.
Dr. Gordon, I have a question. If you
Okay,
could just
can I
linger
go
on the,
I have one more slide. So
oh,
can we
go for it.
Okay. So for the this is out of England. This is something that we're watching very closely. The CDC also monitors deaths associated with it, but I couldn't find something that was recent. This is actually goes up to 2020, so I thought it was pertinent for our discussion today. They looked at any deaths that were associated with cannabis that came in via toxicology reports and on autopsies. And you can see on the major slide there, you see that there's been a dramatic increase over the last 6 years, 6 or 7 years in England with cannabis-related deaths, cannabis use in relation to deaths in England. And that's also, remember, going back to my anecdote, my satellite slide earlier, this may be a lot of polysubstance use that we're seeing. We may see a lot of these deaths may be because people are using marijuana as well, or cannabis, and then also using other substances and causing overdoses and death. And that's the major concern. Last slide here, just to summarize, and we'll get to the questions. So some summary points to hammer some things home, at least from my read of the literature, is that we know that cannabis use is increasing, much more permissive, a lot of decriminalization of marijuana across the country right now. We know that THC content in cannabis is increasing. It's not the medicinal side of what we use medical cannabis for, and certainly people are using it for the euphoric effects. Medical cannabis, the THC content is relatively unknown. A lot of medical cannabis states are having problems kind of understanding what is the type of cannabis that is actually being dispensed to the population. Fourth, morbidity associated with cannabis use is not trivial. We do hospitalize people who have severe cannabis use disorder. Inpatient and outpatient addiction programs are seeing a much increased amount of people who are having problems with cannabis use disorder over the course of the last 6 to 10 years. I'm sure many of the addictionologists on the call would say, yeah, we've seen this. It's actually increasing even in Utah. Adolescents and youth are using cannabis increasingly, so more exposure in adults. You'll have more exposure to kids, especially in medicinal purposes. Cannabis use causes cannabis use disorder. Pretty clear. NIDA is very firm about this number, and is very clear that there is, if you are a regular user, you're going to have, and you have a high THC content to that regular use, you're going to have the symptoms and signs and the criteria for use disorder. And that means that you're having harm associated with that use. Adolescents and young adults are most likely to evolve to cannabis use disorder, not just the use, but also the disease itself. And medical cannabis, by this study recently, has implications for maybe actually causing that you're providing a medical cannabis card, people are using cannabis, and then all of a sudden they're starting to receive pretty quickly use disorder characteristics. And then finally, just because of the polysubstance use, we rarely see, I've never seen actually cannabis use itself causing death. The sequelae can. Certainly some of the harms in your body can cause that. DUIs can cause that, for example, too, when you're using marijuana or cannabis. But certainly the concern is polysubstance use as well as other issues going forward. So with that, I am at the end of my 30 minutes. I have 10, I did it on time. You said 10 minutes of discussion. We have 10 minutes of discussion. I will say before
I want to say, Adam, we extended the time to 10:20 to give you a full hour.
Oh, no. I'm following the agenda. No, you're
Well,
okay.
you may be surprised how many questions there are, or not, or comments. So
Well,
we just wanted to allow for that time.
Okay, that's fine. Again, I want to point out too, even though I've done a lot of work in this area in terms of medical consequences of cannabis, we've reviewed a lot of literature, et cetera. And I'm an epidemiologist, associate chief of epidemiology here at the University of Utah. This is a nascent literature, as you mentioned even earlier in your board meeting. A lot of this stuff is still unknown. We cannot often in research do a cause and effect of cannabis. We can't. We're often relying on observational studies. Some people are using cannabis are more likely to have heart disease, or they're more likely to have lung problems. So there's always an implicit problem of causal inference or causal relationships. So it's really important that the literature here that I mentioned about the percentages, et cetera, some of it is grounded by cohort studies where people have been following people along and seeing the increased incidence based on the exposure to the substance. But there may be other exposures that cause it. However, if you're using cannabis and you're using on a regular basis and you're youth and you're using on a regular basis, it's pretty clear from multiple studies that the risk is really high for having a cannabis use disorder. And I didn't show a slide here, I should have. The VA, I work in the VA, the Veterans Administration. The number one problem that we're having right now in the VA, the rise of addiction, is really cannabis use disorder. And problem is that there's very little treatment that we have for it. We have conditioning management, we have other non-disease-based, non-pharmacological treatments for it. Brief interventions can work sometimes, cognitive behavioral therapy can work, but it really requires an expertise. And a lot of providers don't have that expertise that are out in rural areas that we have in Utah. So unfortunately, even though that people have a cannabis use disorder, oftentimes it's either unrecognized or it's undertreated because we can't get people, there's not the benefits, insurance benefits to get adequately treated, or there's not an addiction program or physician or practitioner that's available to actually address this problem. With that, I'll stop. So I have some caveats on the end. I'm certainly not the foremost expert on marijuana and cannabis, but I'm happy to answer any questions that you have.
Adam, thank you. I mean, the tremendous presentation, and I know that people will have comments and questions. I just wanted a clarification on the slide. It was, I think, toward the end with the cannabis card, this one,
Yep.
that there was increased incidence and severity of CUD, but no improvement in pain, anxiety, or depressive symptoms, and improved self-rating of insomnia symptoms. Can you just clarify that a little bit?
Yeah, it's what it is. Remember, it's a 12-week process, so maybe we're not going past that 12-week that you're seeing improvement. This would be another thing about saying, does really insomnia treatment help with marijuana, with medical marijuana?
Yeah.
I can't. That was an incidental finding kind of thing, that they wanted to look at some of the outcomes associated with what the indications were. To say, well, is it a benefit and a problem, or is it just a problem? And at least in this study, for a lot of the indications, or like insomnia, it was more of a problem, that people were actually self-identifying with problems of the use disorder.
Yeah. Okay.
This was
Yeah,
a
we
nice
found
study
that in
too.
our look.
A
at
lot of the
insomnia.
epidemiological studies have to do with a lot of surveyed, so that people are asking, well, do you have this symptom? Do you have this symptom? Do you have this symptom? Whereas this study was a prospective study where actually had trained people who were looking at all the criteria. So this is actually one of the stronger studies that indicate that incident use of medical marijuana caused some use disorder symptomatology.
Yeah. Okay. Thanks. And so I'll stop after this, but I'm struck by, I think we all struggle with understanding the meaning of a use disorder and how it's harmful. If we see deaths and causal relationship, we worry about a use disorder. But, short of that and a couple of other things, I think we don't quite see, how, we saw this with benzodiazepines and opioids. The use of the treatment, starts to look like the problem that you're treating. For example, anxiety or insomnia with benzos, initially helpful, but at some point not helpful, higher doses not helpful. And then you start to lose, what are you treating? What's working, what's not working? Same with opioids and same with cannabis. It's a lack of understanding or something with the harm of tolerance and dependence and withdrawal. I think that sounds very medical and manageable if you just keep taking the medicine like you're supposed to. Yet the harm, and especially with youth, I think we don't quite understand. So, you know, I think that I would love to hear your comment on.
Well, let me
kind of-
comment. It's a vicious cycle.
Yes.
And so the problem is, especially for marijuana. Now, I treat all addictions uniquely, right? Every addiction is like hypertension, diabetes. Everyone's a little bit different. There's some commonalities, but for marijuana especially, many patients get tolerant to it, right? So if you're having problems with, and you're using it for a certain indication, and then it's not working as much anymore, and you're kind of starting to feel bad again, you're going to try to take more THC type products because you think that's what's going to help your symptomatology, and you're just making your addiction worse for the most part. You're getting tolerant, you're having problems. I think the other big thing, and Katie, you can definitely mention this as well. We see patients with addiction all the time. These are devastated patients. These are patients who really have problems, not only interacting with their family, but society overall. So you have someone for marijuana, for example, you get this anhedonia. You feel like you don't want to do anything. You're not interacting with you're not doing your role obligations at home. You're not performing well at work. You may be late to work. You may be taking time out of your day to find the best THC product available. And that detracts from your home environment and your societal involvement. So it's just a vicious cycle. So, and oftentimes it's not recognized. You know, maybe the patient, especially for marijuana patients, they think, oh, well, I have to smoke more. If I smoke more, I'll feel better. I'll feel less, more in control of what's going on. And it just becomes, especially for a patient with addiction, it's just a vicious cycle. It gets worse and worse the more that you use. And you see this. We see this a lot in opioids, especially, but we see it also in marijuana. If you can get people off of cannabis, and all of a sudden they have more of a spark in their life. They're actually saying, "Oh, I'm talking to my wife again, or I'm talking to my husband again. I'm interacting better. I'm more clear." The clouded sensorium is also another big issue. They just feel like it's much easier to operate and to react to society in different actions. You know, job, housing, etc. So, but it is. You know, I wish I could have, next time I should bring a patient for you guys to talk about it and have what their experience was when they were using THC versus when they're off of it. And it's like night and day. I see Dr. Fine. Dr. Fine, nice to see you again.
Hi, Adam. Thanks again for participating in our board and for once again going through the exercise of reviewing the literature and helping us to understand epidemiologically what's going on. You know, in this list, you've got this slide up, so I'll sort of refer my question to this and then get back in the queue because I see Mike's got his hand up too. It seems one of the most early and common problems sort of in this categorization of indicia of use disorder over the last, I don't know, 40 years of medical practice for all sorts of substances and substance use issues is denial, is the expression that I don't have a problem. I'm using it for this purpose and it's solving that purpose. And they really don't, there's almost a blindedness to the negative effects and the problematic effects and the defensiveness about use for a positive endpoint, whether it's alcohol or psychoactive substances of a sort, especially, whether it's amphetamine-like drugs, benzos, whatever it is. And now we're talking about, and opioids, of course, the most obvious. And then, and the discerning nature of how we have to use drugs with problematic potential use for medicinal purposes and have extraordinarily tight structure and selectivity but also early recognition of when there is a problem so we can in fact address it quickly before it does become off the cliff. This denial seems to be this huge impediment. I'm curious why that's not on the list as an early indicator of, especially in people interacting with medical community, this is something you might see and deal with before you see any of these other sort of problems. Obviously, rapid dose escalation, which is sort of the other side of that coin of tolerance. Rapid dose escalation without seeing objective improvement in whatever a measure of health you're looking for is sort of another obviously clear issue of maybe we got a problem here. So could you just comment about that, and should that be on the list?
Yeah, well, I mean, that's a hard question. I'm not going to go back to DSM-5 committee and say you should have put this on the
Right,
list.
right.
It has not been a common thought of what addiction is. This lack of recognition. I think the criteria was on the screen about loss of control is part of that you kind of lose sense of what the problem is or what the issue is. So in some ways, you could, if you say I unrecognize the problem, you potentially have that loss of control over that substance. That being said, I think it's really important especially when patients with addiction, all addictions, especially marijuana and especially people with prescription opioid use, you want to make the diagnosis colloquial. And what I mean by that is you want to have a conversation in a non-threatening way. Many of these patients don't want to be labeled as someone with abuse or someone with an addiction. So oftentimes when we go through the criteria, we don't read a script and go, boo, boo, yeah, this, because that's the worst way of actually getting anything out of somebody. So you really want to make it colloquial. Say, hey, has anybody talked to you about your use at all? Have you had problems? Is your significant other saying that you're not doing things? And sometimes they'll say, oh, it's because of my pain. But then you can say, well, what were you doing at the time that you were actually, when they were saying this? And it may be because they were smoking marijuana. So there's some colloquial ways to get at it. And I think the addiction disorders are all very paternalistic in many ways. You kind of like you're labeling somebody, and there's a stigma associated with that label. So we have to make it a little bit less, make it a little bit more colloquial and say that hey, there's some things going on in your life that you're having harms associated with it. And I need to be aware of that, and I can help you get treated for it. And I think by doing that, you make them recognize, I think, this as a clinician, you make them recognize that, yeah, my opioids is causing problems. Yeah, my alcohol is causing problems. My cannabis is causing some issues. And having just a discussion about that, not immediately saying, hey, you got a cannabis use disorder. Oh my gosh, go to Katie's program. That's not the attitude. We need to kind of ease people into these diagnoses, especially when you're in an outpatient setting and you have some time to have a good rapport and communication with people. I will bring up, Perry, though, Dr. Fine, I'm sorry, I will bring up this idea of unrecognition. There are several people who are actually starting to convene the DSM-6 committees these days. And I'll point out that may be something to think about. If you're unrecognized disorder, maybe that's a criteria to be considered.
Just a quick follow-up, Mike. I'm just curious, Adam, just as a quick yes or no. Yeah. Do you know whether the Health and Human Services Committee in the legislature are aware of the very high incidence of cannabis use disorder
no.
through exposure on a regular basis?
I say no. It's a like other hallucinogens, weed, marijuana is thought to be safe in many ways. And oftentimes, sometimes, if you see people around you smoking and they go kind of nutso and they're having a bad day and they're smoking too much, most people around them say, oh, they're just having a bad trip or just doing weed again, not recognizing that actually is, harbinger of a lot of problems in their life. Therefore, they have the use disorder diagnosis. And I think a lot of legislators, remember, we're looking for a cure too. We're looking for things to help what ails us, right? And healthcare in general is not sometimes thought of as a place to go to get help. And so the undercurrent of society is we want to escape it. So maybe taking some marijuana joints is I'm gonna feel better. I'm not gonna have to go to see a doctor for my XYZ. And so, it's one reason why you've had me talk 2 years ago about opiate use disorder, right? Does marijuana, are we trying to find another cure for opiate use disorder? No, the cure is to go to healthcare. It is to get into good healthcare evidence-based practices. We don't pay for it very well. patients don't want to go to it. There's a stigma associated with it. So why not just use marijuana for my use disorder? And I think those are the kind of messages that legislators are hearing from the public. And especially in rural areas where there's not a lot of access to good care, et cetera. That's just I'm going on a limb here. That's my pontification, all in my humble opinion. IMHO. Dr. Moss
Dr. Moss.
Dr. Moss knows probably more about anything about problems of marijuana than I do. So I'm going to let him tell me what I said wrong.
Oh, no, I just, I want your take on something here too. And Perry, maybe Rich too. I think prevalence of cannabis use disorder in Utah medical cannabis patients would be a great research project for the new Center for Medical Cannabis Research at the university, or anyone else who wants to take that on. But, my question, Adam, specifically was something you kind of got at here. We frequently get comments to the board about, well, cannabis is a trade-off. Instead of using opioids and benzos and those things, I'm doing this instead. So who cares about a cannabis use disorder, because my alternative is dying from opioid benzo overdose. No one died from marijuana overdose. No one died from marijuana withdrawal, but they certainly do from alcohol, opioid, benzos, et cetera. So how do you do that whataboutism, or the trade-off side of this is better than what we used to have, so who cares?
Well, I'm going to put on my addiction medicine hat here. We treat diseases all the time that are coexisting, right? I'm an internal medicine physician as well. If it's an analogy to medical disorder of hypertension, diabetes, and let's say cancer. No, cancers are probably bad. Well, I'll just say hepatitis C. So hepatitis C, hypertension, and diabetes. I'm going to die from one of them, so just treat two of them, and therefore I'm not going to, and I don't care about the other ones, because it's better than, as per your analogy, it's better than nothing. My point here is that we have to think of addiction disorders as separate entities, and it's very hard for a lot of our institutional addiction programs to do this just because of the programming that they have. Many addictions have a common final pathway. We actually know that if you treat, for example, opiate use disorder, you're less likely to have use of methamphetamines or cocaine that you're co-occurring. So if you treat one disorder, you're likely to help the other, especially in formal programs, because they do some common final pathway, reimagining, rethinking, getting your brain rewired to start thinking more normally rather than trying to chase a substance. So getting people into treatment is really important. And I think what we've seen, if you get into treatment, your general other substances like cannabis would go down a little bit. But the biggest issue, though, is let's say we get people into treatment for opiate use disorder or alcohol use disorder, and we don't address the cannabis use. Well, then what we're left with is we're basically saying, hey, that disorder I don't care about. Don't worry about that one. We'll just deal with the ones that are really scary. And what happens then is that the problems of that addiction continue in that patient's life, even in the treatment or even after the treatment is over. So it's one reason why, in many respects, we've changed our paradigm in addiction care. Well, there's a shift. The abstinence-based kind of model versus more of a harm reduction approach. So, to really treat addiction, you really need to be working on all the substances at the same time, or sequentially in a safe environment. And using a harm reduction approach could be good to treat two of them or the more severe one, but that other one's going to nip you in the bud at the end. And there's been a little bit of work in this area in the literature about looking at, do we ignore cannabis use because we want to deal with the more serious products? My take would be is we have to address all of them. We're going to get some of them in good evidence-based care, and some of the treatments like for cocaine or methamphetamine actually work pretty well for marijuana. When I say treatments, I'm talking about non-medicinal or non-pharmacological approaches to care. And so you're kind of you are dealing with it in some ways. The last thing I'll just say, I mentioned this briefly. I think we have to be careful about being permissive and saying, I don't care about that disorder. It's not as important as providers, because if you do that, the patients get that message that, oh my gosh, he only treated the more severe ones, so therefore I'm going to keep on smoking, and that probably is a very bad message to do. And I see a lot, I see Dr. Carlson shaking her head. I mean, it's a hard problem. It's polysubstance use. It's a very difficult thing to treat. It is extremely difficult. And you have to be in a very intense program or have a very clear outpatient approach to these patients. But we don't want primary care providers to deal with polysubstance use because they don't have the resources, the non-pharmacological treatments that really can help with some of these things. So that's my take on point of that question. What do you think? Can I ask Dr. Moss what he thinks?
Well, certainly I don't see the same, level of harms from cannabis on my poison center and toxicology side. But just exactly like you said, are we causing an additional harm? And is this patient really being benefited if the goal was to treat whatever that condition that they used to be using opioids or benzos for, and I've not actually helped them, but instead I'm harming you with a cannabis use disorder, then I haven't helped anything at all. And the alternative is not die from an opioid overdose. The alternative is find a beneficial treatment for whatever medical problem that you had to begin with.
I gotta jump in.
Can I give a follow-up question? I'm sorry, Dr. Moss, have you seen on the inpatient side at the University of Utah people with cannabis intoxication or withdrawal?
We definitely get some. I mean, most of what I'm seeing is severe opioid withdrawal and people with endocarditis, and they're psychotic from their meth use and things like that. Some of it, certainly patients who get the hyperemesis syndromes, the cyclic vomiting syndromes that we see more often on the hospital side of things. Yep. Certainly some patients that are feeling some of that poor sleep and feeling crummy as they discontinue their cannabis use to some degree. Most patients who get too high come to the ER and are able to go home from the acute sort of like panic reaction side. And then the other ones who are getting those psychotic episodes are ending up on inpatient psychiatric side rather than our inpatient medical side.
Yeah, very informative. Have you seen an increase in that over the course of the last several years, you think?
Oh yeah, for sure. For sure. A lot more. I did fellowship in Oregon when they were getting recreational cannabis, and it was all just exploding at that point as recreational cannabis flooded the state.
Yeah, and think about this. I mean, I mentioned a little bit about some of the costs associated with treatment. I mean, if we're having all these increasing coming in, I mean, there's a lot of cost to care. There's opportunity costs of providers now having to take care of more people with these cannabis disorders within intoxication, withdrawal, use disorder in a variety of healthcare settings. And that for addictionologists, I mean, we know that cannabis use disorder is difficult to treat because of some of what Dr. Fine mentioned, but also, we don't have a magic pill. We don't have a magic drug to treat cannabis use disorder. So it often requires a constant engagement, non-pharmacological approaches, and that's a lot of cost to the insurers as well as to the out-of-pocket, or but more than likely, more people are not just getting treated at all. And that's the other big concern, because then you're getting all these people that are not productive or having harms associated with their life and harming others. And that's not good for society. Sorry to interrupt, Dr. Carlson.
Well, this is exactly what I was hoping for, this type of discussion. I think we still, because of our tools and the way we think about human suffering and improving well-being, we still are limited to things like toxicology reports, hospitalizations, emergency room visits, obvious harms, criminal activity that leads to arrests and warrants. That's still how we measure substance use problems. So the demon drug concept is still out there. And what happens, so that actually works to the advantage of someone who's struggling with cocaine use or heroin use that's illicit and causes harms right up front. If not in the first, 90 days, certainly in the first year, and it's rapid and it's obvious to everyone. When you shift to something like cannabis, the problems are more insidious, and we don't have the tools to measure, recognize, or intervene. And I think that, again, we're pursuing health and we're looking for cures. And so we're not held accountable for how our efforts to cure something are harming the very person. You know, we see that over and over again with medicine. Some, you know, estrogen is going to cure all these problems. Well, as it turned out, maybe it didn't, or the type didn't. And then we change, but by then lots of damage is done. And that happens most often when the damage or the harms are to young people, and to people who, rather than kind of having positive impact, you know, measurable, not positive in terms of good, but, you know, positive, recognizable, like hitting up the ED, getting hospitalized, getting arrested. So when the harms are happening to young people, and also in a way that just leads to kind of a quiet withdrawal, a quiet missing developmental markers, missing regular achievements, missing the foundations of building a social network that's going to help you in the future avoid some of the more severe harms, physical, mental, social. So this gives me great angst. And from the moment we started with this, we're looking for benefits. We're looking for cures. We don't have the eyes for the potential downsides because we can't measure them. We can't see them. They're not spoken of. And I think that also, just final point, you know, Mike, when you said, well, it's better than opioids because no one dies from an overdose of cannabis. Well, again, we're measuring death. It's like, we'll care when someone dies. And by that time, great damage has happened. But there's damage being done already by the time that happens. So I just, you know, when someone comes in and they first of all, they don't come in for, I have a cannabis use disorder, I want you to help me. They come in because of court problems, interpersonal problems, financial problems, homelessness. Those are caused by the other substances that they're using. And so when we treat cannabis use disorder or even problem cannabis use, but you can't treat it the same way. You can't treat it up front. You develop a relationship. You educate. First of all, you have to overcome the public health message that cannabis is medicine. Cannabis is good for you. Take your medicine every day. So you got to first overcome that without alienating the patient. Then you have to see where are they? What are they interested in? And this can take years. Whereas heroin, you can start them on opioid replacement, heroin, fentanyl. You know, there's no magic pill for methamphetamine or cocaine, but there are a lot of interventions that help, including addressing the co-occurring heroin use that often comes with those. But cannabis, you gotta just go slower, and you gotta educate, and you gotta understand, and you gotta listen. And as Adam said, there are lots of obstacles in many health settings that prevent that. And so it's not so much that, oh, the patient has denial, and so we can't touch that. It's that it's a different type of intervention that doesn't look as dramatic or instantaneous as interventions for other substance use disorders.
Yeah, and I would just add to that you know, our treatment system, our addiction treatment system, is not prone for longitudinal care. We often are episodic care. So, you know, as many of you know, I'm really championing that we think of addiction as a chronic disease and a long-term problem, and integrating within long-term healthcare settings is probably the best way to go. The last thing I'll just say, based on what you said, Dr. Carlson, is you know, medical marijuana or medical cannabis, you know, it's the last hope for many of these patients. Many of these patients say nothing else worked, or I don't want to work with anything else, so I'll just do medical cannabis. And so what's the message then? We've given you this something to take for a treatment, but 10% of you or more may have eventual problems associated with that use. So you're creating a problem by trying to fix a problem. And patients don't want to admit that, and providers don't either. Anyway,
So
Dr.
along those lines-
Dr. Berner was on, I think, had a hand up too.
I just want a quick sort of administrative point, because before we lose Adam, I see that Michelle McComber from the Utah Medical Association is on. And I'm sorry that I was hoping that Dr. Hoffman, who's our sort of the liaison between our committee and the health department, is on. But I would think that the recommendation I'd like to make is that, and maybe it could be made through you, Rich, maybe you're the most logical source, is that this presentation be made to the interim Health and Human Services Committee during the when they have their interim meeting in the fall. At the same time, we would give our annual report. Dr. Carlson and I will not be. Brian, you're going off too, right? This is the end. So I think 3 of us are no longer going to be on this. Matt will be taking over as the chair, and I think it's just critically important that the legislature, through the Health and Human Services, hear this message. What they do with it isn't, but I think it's a balancing point when what do we have, Rich? 65 going on 70,000 with an estimated moving towards 100,000 people being exposed on a regular basis to what we suspect are relatively high dose THC products for medicinal intent. Are we curing one problem with another by adding to another problem? Sort of to your point, Adam. So if you'd be willing, Adam, I just think it's a critically important message that has yet really to be delivered with the impact that the epidemiological review that you've done has. That's all I wanted to.
As you know, I'm at your beck and call. You all can use me for whatever you want to use me for. Thanks.
Yeah, I second that. I'd see Mike, Dr. Moss, please.
My last comment would be, with this potential for cannabis use disorder in medical patients, are there recommendations that we can make as a board to reduce that risk for new patients? Maybe there's no evidence or literature out there, but maybe this goes around to dosing and how much cannabis patients are allowed to have, so that they don't just show up and then get a whole, arms full of cannabis and they use as much as they want and then get themselves into trouble. And are there sort of dosing and dispensing recommendations as far to quantities or titration above and beyond the dosing guidelines we've already put out that could reduce the risk of a medical patient developing a cannabis use disorder? And I don't know if there's an answer to that question.
That's a great comment. I mean, I have several things that I would say that we could do. I will say that when you get a medical cannabis card in general, a lot of states, you have it for life. And there's not really any post follow-up of patients. I could think of a system where you have a card for a year or a card for 2 years. And in order to get your renewal, you need to have an assessment of your original disease and how well you're doing on marijuana or medical cannabis. And maybe even making sure that did you would assess if there's any problems associated with the cannabis use, and have that as a guidance going forward. I think having more regular follow-up would be a very easy thing to do, and we should be doing to follow up for outcomes. We want to make sure we know if we're doing well with the medical cannabis product, but more importantly, are we causing other harms associated with it? And you have an evaluation at the University of Utah, you have maybe a center going on that may happen here as well. Those type of evaluations are really important, and guided by science and how to do a quick screen and how to evaluate people going forward is really helpful. Dr. Viner actually has his hand up a couple times. I want to make sure we don't.
Well, let's let the board have a chance first. Dr. Gordon, we do have time, and we're always happy to see Dr. Viner on our call, but we will have time for the public comment. I want to actually, we have members of the board who are qualified. I mean, we're all qualifying medical providers, but who have a lot of direct experience with patients. I would love to hear from any of you who maybe want to weigh in.
Well, maybe I'll start. I really appreciate your presentation, Dr. Gordon. It's certainly very relevant and important information as a prescriber to really keep this in mind. A lot of my thoughts revolved around managing the patient and doing adequate follow-up, like you said. And when you quote some of the research, what I would like to see going forward is more detailed research, like distinguishing between some of the patients, like Mike suggested, is there a correlation between daily use at above a certain dose that was more correlated, just with bad outcomes or addiction than someone who followed prescribing guidelines and follow-up and didn't use daily? A lot of my patients don't use daily, and it's great. And so I would love to see research that distinguishes that and say, if you follow treatment guidelines, your risk is reduced by X percentage than someone who smoked the crap out of it, and had addiction and bad outcomes. So that's what we need now for a prescriber to distinguish, because saying that just having a medical card increases your risk by 10%, well, yeah, that's like saying having a driver's license and driving increases your risk of getting in an accident. Well, if you're off the road, then you won't get an accident. So we need a bit more detailed information so that we can treat patients with confidence and show them the fences. As long as you're in these fences, your risk is reduced. And that would be very helpful moving forward.
Totally agree. Great points.
I make a quick comment, Katie.
Yes, please, Rich. I was just going to ask anyone else on the board or in the department to please comment. Go ahead,
Great.
Rich.
Yeah, I'll be very brief. So I think one thing to recognize is that there are a number of providers in our current program that I think follow the guidelines and meet with their patients at a frequency that is, helps with that long-term treatment plan that they've developed. And I acknowledge that in some cases, there are providers out there that aren't as, I think, thorough, aren't as diligent in those follow-ups and following up with the patient about this specific type of product that they consumed. And so I just want to acknowledge the spectrum that's out there in the program today. And also one comment that I just wanted to follow up on is there was a comment made about the number of young people in the medical cannabis program. And I just wanted to provide some data on that. So right now, or as of the end of last month, there were 69,016 total medical cannabis cardholders. And of those, 146 are under the age of 21. And of those that are under the age of 21, let's see, between 18 and 21, there's about 62. So that's what the population looks like. And all those applications go through the Compassionate Use Board. And Utah has set it up a little bit differently than other states. And there's, I think, a more intensive vetting of those type of cases than there is in most other states. And there's a number of strategies that we have in place today that I believe make our program unique in its way of addressing some of the concerns that have come up in the discussion. Although there's always room for improvement and additional things that could be done. If there are factors in place already that help manage that in the right way. It is true that there is a lot of discretion that is given to the medical provider. The medical provider in Utah's program has the ability to limit the time frame of a card, and they also have the ability to specify limitations on the type of product that a patient purchases, and they have the ability to, as a condition of certifying a card for a patient, as a condition of that, they can say, I want to meet with you again in 30 days. And if the patient doesn't comply with that request, they cancel the appointment and don't reschedule, then they do have the ability to no longer certify that patient for a medical cannabis card. And so there's a high level of discretion that is given to the QMPs. Some QMPs really manage that closely and others don't manage it closely. But I want to emphasize that our program has some of those checks in place already.
And but the trends are to make this more available. That's really, I mean, we try to make it safe, but the push, you know, for example, originally follow-ups had to happen every 3 months. Well, that was legislated out of the program. And then there's also an effort to get cards very quickly. So a waiting period was eliminated. And that pleases people in the program. And yet we're hearing that, one other thing, you know, there's efforts to make this more available in rural areas. Well, I'm picking up things from Dr. Gordon's presentation that immediate access to the cannabis card is correlated with some problems, and frequent follow-up can prevent some of the development of the unwanted outcomes. And so, you know, I think it's the hard reality. It's not so much the Utah program. It's just the kind of tide that we're all riding in on. And I do think that Utah, you know, including our forensic lab, we have a lot of advantages that other states don't have. But I'm not sure, you know, what I take away more from what Dr. Gordon is talking about is not exactly what can we do as a program to reduce harms. It's almost more what does the public need to understand? What do legislators need to understand? What do physicians need to understand, whether they're in the program or not in the program? That's what I'm hearing. What Dr. Gordon is providing us is kind of the context, the backdrop of what our program exists in. And I think that that's really important for us to be aware of. And I cannot emphasize enough my support of Dr. Fine's suggestion that this presentation be delivered to the legislators. I like that interim session or the fall session that you're talking about, Dr. Fine. I really would love to see that happen. And I'm hoping, Rich, you and the department can help facilitate that. Dr. Gordon's willingness is appreciated. I also think, you know, the Dr. Christensen in the medical examiner's office, who he sits on the Controlled Substance Advisory Board. I think that would be a very important target for this presentation. And Dr. Gordon, I can talk with you offline if you'd be willing to do that, if there'd be, yeah, but because that's what we're really trying to do is connect all these dots. And so I just, again, thank you, Dr. Gordon. I know we probably have hit our time limit and then went over some, but, and thanks everyone for the great comments and questions. I hesitate to censor anyone. So is there anyone else on the board who hasn't had a chance to ask a question or make a comment? Okay, well, we will move on to the next agenda item. We're landing back on planet Earth here, and Rich, take it away. It's updates from you. You're muted, Rich.
Oh, there we go. So thanks for the chance to just share a few updates. During our previous meetings, we talked about legislation that passed during the last legislative session. A lot of those laws, those amendments that passed became effective last week on May 3rd. Most of them became effective on May 3rd. So we've educated the industry about those changes. We had a meeting last week with representatives of the medical cannabis pharmacies and the cultivators and the processors and advocacy groups to make sure we're on the same page on many of those changes. And we've got a follow-up meeting this week with representatives from some of the medical clinics, and we're sharing some general information with them about some changes that went into effect last week. And so that's just an update on that. The University of Utah Center for Cannabis Research is hiring a senior manager And this is someone that will help with the implementation of the HB 230 that passed during the 2023 legislative session. And this is someone that will work with the what they call the Research Program Development Team, the Senior Vice President of Health Sciences Research Unit at the University of Utah. And though this person would report to the Director of Research Program Development there at the University of Utah. And so that job is open now, and we're excited to work with the University of Utah long-term on some goals that they have and some mandates from the legislature that they are ambitious about moving forward on. Also, we've been coordinating with a vendor to write requirements for our new software system. As I think has come up previously, we're moving from our current vendor to a new software using this Salesforce software platform. And this is both the electronic verification system used for patient registration and also the inventory tracking that's used for tracking products from 8 inches tall to sale. And that is on track to roll out in spring of 2024, potentially earlier. And we're excited about that. Also, let's see, right now we're at 69,016 medical cannabis card holders as of the end of last month, and about 930 medical providers registered in the program. And also Sarah Ponce and I are attending the cannabis regulators meeting. And there's some sessions that really, I think, connect with some of the work of this group. For example, one of the sessions is on ongoing challenges with cannabis research. How can regulators help advance science? So that is a particular session that we'll share some information with this group about after we attend that. And we're excited about it. So yeah, that covers agenda item number 5. Looks like the next one is just a board member term ending. So we do have, or actually, are there any questions about any of the information I shared in the Center for Medical Cannabis updates from the group? Okay, seeing none. There are 3 board members who are rotating off the board at the end of this fiscal year, at the end of June. And so those are Katie Carlson, Perry Fine, and Brian Zender. And so we are so grateful for their service. Obviously, Katie and Perry and Brian have been a core part of this important board for many years, and we're grateful for their service. And with that, we are also working with the governor's office and our executive director on identifying individuals to replace them. And you're welcome to share any names of individuals that you feel like should be considered. We've got some names already, but if you feel like there's additional individuals that should be considered, you're welcome to share those. One thing that's unique about Dr. Carlson's position she is also on the Controlled Substance Advisory Committee for the state of Utah that works with the Division of Occupational and Professional Licensing at DOPL. And because of her unique position, we're looking now for a member of that Controlled Substances Advisory Committee to replace Katie as the representative from that committee on the board, because statutory mandate is that there be at least one member of that Controlled Substances Advisory Committee to be on this board. So that's another item we're working on as we prepare for the new fiscal year beginning in July. And item 7 is just that I wanted to let also those board members that are remaining on the board, that includes Misty, Matt, Mike, and Jennifer. While we're looking for new board members, we also need hopefully some interest in serving as the new board chair and vice chair. And so I just wanted to encourage the board to, if you're interested in discussing that now, you're welcome to. And if you're interested, you're welcome to indicate that, or if you're interested in nominating somebody else to serve in that role for the next fiscal year beginning in July, you're welcome to indicate that. So I'll just turn it back to you, Katie, and the board for discussion about the new board chair and vice chair.
Apologize, there's suddenly a lot of background noise here, so I'm gonna be real, I'm gonna try to relocate. Well, so are there, I would just turn it to the board members, actually, if there's any questions people have. I think part of this maybe is gonna take place offline to get to the nitty gritty, but just any comments, comments or questions or discussion, please take it away. But before I do that, I want to thank all of you for this opportunity. I served on the board. I was trying to think of when this started. Maybe Dr. Fine, I was not on the first round of the board, but maybe the second year. I don't know if that was 2018, 2019. And then I've been chair for the past year, and I just want to say for the record that it's been a tremendous experience. I've learned a lot from the board members and from the department, and I have really been honored to work with all of you. And so thank you for that. And with that, I will turn it over to the board for any discussion about future member opportunities.
Just a point of clarification, and Katie, a year ago, when my term was concluding, we went through the process of determining how we would proceed. We kind of got off schedule a bit because the chair is supposed to be a 2-year term. I served a 2-year term, but Katie only had 1 year left, but she had agreed to, with the amount of experience she had, she stepped forward and said, I'd be happy to serve. And then Matt agreed to follow in her footsteps with a full term and assume the chairmanship. That's as far as we got. So my understanding is that we went through the process, good process and so forth, totally above board and clear that Matt would now be the successor chair for the next 2 years, but that we also need now and Katie would be in absentia, the immediate past chair. I will be also gone. So we need to determine the process of somebody stepping up and being willing to be the immediate incoming or vice chair, and that probably is best done offline. But I too want to say thank you to all my fellow board members. It's been a very interesting, in some ways challenging, also very rewarding 4 years working with you. I want to especially appreciate all of your integrity and hard work in staying true to mission. Our mission was designated by the legislature, a lot of buffeting forces, including this sort of push to have to serve on a research board, to have members who would be prolific recommenders of cannabis. I think it's very important we have that input. Matt, Brian, I've got some, Katie's qualified provider and so forth. But
Dr. Norris as well.
And Dr. Norris, one can have expertise in evidence reviews. Lauren is a perfect example. And do and Misty as well, a superb job without necessarily being a personal user or a recommender. So I think that there's been efforts at sort of getting off of mission and our purpose, oftentimes by the very people that signed the mission in the first place. So it's been challenging in that way. But I think that I want to tribute all of you on the board with being true to mission and focusing on the objective indicia of what the research and the evidence shows and where we need to learn more. Now, I've been asked as I step off of this board to participate in the newly funded and University of Utah Research Center. The only concern I had, and I discussed this in great detail with Rich when this was coming up before legislation, we were getting feedback about this, is that we want it to succeed, and to succeed, it has to be adequately funded. To be adequately funded allows it to actually then go after bigger grants and be able to actually do meaningful research. It would be a shame to have this opportunity die in the dust before it gets started from insufficient sunshine and water, which is what funding does. But I guess, Rich, I'm correct. It's got $600,000 to get it going, which is a substantial fund, and I think that's a tribute to recognition that and the feedback that it does need to get underway. We're trying to find leadership, as Rich said, and we'll see. And maybe Rich, since you're the sort of the continuity here, and Matt, maybe some report in the next maybe 6 months from now about how that's going. A formal report would be a good thing to have, just so the Cannabis Research Review Board can sort of be connected in some way informationally with what's going on in that center. So with that, I just want to say great thanks. And Rich, I want to turn to you for a moment and acknowledge that you have been a common thread for the last 5 years, at least in my interactions with the board. My discussions with legislators began 10 years ago in anticipation of a program like this. We were highly aspirational. We really wanted to go all out in terms of following science and have a great signal to noise ratio, meaning that all these other political, economic, commercial, advocacy related, all these other interests would be heard, but that wasn't the purpose of the board per se. And Rich, I really appreciate the fact that you have stood steadfast in supporting this board in being an intermediary with the legislature, since we're not a political group, and in helping to sort of keep that important filter there so the message doesn't get lost about what our intent and purpose is. So with that, I just wish everybody great health. That's what is probably, as we all know, more important than anything. And for all those in the public who have continued to weigh in on a regular basis, thank you for your helping to inform us as what's important to you. So fare thee well, and we'll see you around in other circles.
Thanks, Perry. I'm going to actually suggest that we move to public comment. The board and skip the board comment because we did a lot of commenting. Is that acceptable to everyone? Okay. So I'm going to, Sarah, I'm imagining that you will take the questions from the public.
Yes. So
Okay,
just as a reminder, when you do make your comment, you'll have 2 minutes, raise your hand, and then state the following, what your name is, if you have any affiliations, and then go ahead with your question. And so we'll start with Michelle.
Hi, everyone. Thank you. I'm Michelle McComber with the Utah Medical Association. I don't have any affiliation with any cannabis organizations. I just wanted to reiterate the board's stance on having the presentation by Dr. Gordon and any other presentations that are related given to the interim committee of the legislature, and would encourage you all to make that happen. Thank you.
Thank you. Is there anybody else? That's the only hand raised right now.
This is an unusually quiet public comment period.
Yeah, I'm waiting for Dr. Viner. He raised his hand earlier. Sometimes he steps away from the computer, but I'm still interested in what he has to say.
There he goes.
Go ahead, Dr. Viner.
Hello. Okay, my name is Mark Viner. I don't have any formal affiliation. I'm self-employed in private practice psychiatry in Nevada. I was just I love the presentation emphasizing the withdrawals and needing hospitalization, but I think I've offered the mental health warning for cannabis products, or even in lounges, a sign. But really you should offer like they do for gambling. It says at the end, you got a gambling problem, call this number. So we should be providing the patients with that treatment option right off the bat, like they do with gambling. And then finally, more education, because I think the term we should separate cannabis-induced psychotic disorder from regular cannabis intoxication, where if you do get hallucinations, you have intact reality testing. So I think the terms have to be very carefully described, especially talking about psychosis, and education will help that. Thank you, and congratulations to the board's evolution. Take care.
Thank you. Any other questions?
I'm going to just respond to Dr. Viner's. I'm assuming I don't see any hands and I'm not hearing anything, but I think that's an excellent suggestion, Dr. Viner, that we consider a warning label of sorts, or a resource label. I am glad that you suggested that.
Dr. Moss has his hand raised.
Thank you.
I was also just thank Dr. Viner for his comment, and I think it's a common confusion for psychosis that cannabis intoxication and acutely being under the influence of cannabis is certainly different from the association with development of schizophrenia or other period of psychosis that develops or persists associated with cannabis use, separate from the acute effects where patient maybe feel time is slowed down and they are high currently, rather different from actually having an acute psychosis. And I think that's an important distinction to make, and that distinction often gets lost in some of these discussions. Thanks.
No other hands are raised.
Well, I think that brings us to the conclusion of our meeting. I want to thank Dr. Gordon again, and thank everyone else who attended. And is there a move to adjourn the meeting?
So moved.
Is there a
Second.
second? Thank you, Mike. Okay. Meeting adjourned. Jennifer, did you want to say something?
No, I'm good. I wanted to say thank you all, and thanks for all your hard work, and I'm learning so much. So, yep.
Okay. All right.
Bye.
Goodbye. Have a wonderful day, everyone. Thank
Thanks,
you.
everyone.